Hello guys, we are moving into chapter 11, Professional Boundaries Guided by Respect. So, know and understand the different types of boundaries, whether professional, physical, psychological, and emotional. Describe what unconsented touching. Describe about caring too much and maintaining boundaries for good. So, boundaries of a relationship. To show respect, we also need to make sure that we are holding true to these boundaries between you and a patient. And every relationship is going to be dynamic between you and your patient. It's going to be different depending on the patients and also depending on the patient's well-being, and maintaining this sort of respect between each and every interaction that you're having. Your real relationship goal right now is based on your patient's well-being. You want them to be good. You want them to feel better, right? Dynamic is characterized by a constant change, activity, or progress. Your relationships in this process are going to change constantly with each and every patient, and sometimes even a single patient can continue to change that relationship. So, professional boundaries. I'm sure that you guys are thinking like, oh, I know what professional boundaries are. I understand. That's great. It'll be a review for you. But there are other things that we're going to touch base on. So you will know that professional boundaries is defined as the usual way of talking about physical and emotional limits to intimacy and familiarity in the health professional and patient relationship. There is physical, there is emotional. A physical boundary would be sexual, intimate relationships, sexual harassment. And emotional is psychological dynamics harmful to a patient, or professional, some of the detrimental dependence. Detrimental dependence is sort of when one person clings to another person, and that can go either way emotionally, whether it's from the patient to therapist to patient. Boundaries can be external, which is sort of the time you spend with the patient, or internal, any characteristics that you're bringing to the relationship. And your boundaries are set by these professional code of ethics, federal and state guidelines. They say these federal and state laws say that you can't touch a patient. Well, that's going to be a little different for us. You can't touch them inappropriately, but we have to touch them anyway. Some people, there's this idea that the book talks about that professionals have to be aloof or not friendly or forthcoming. They're distant and they're not affectionate. Which is, I don't think is true. I think the more affectionate and the more friendly you are, the better results you're going to get. Recognizing what a meaningful distance is. The degree of intimacy is often determined by distance. It can be totally separate to right next to each other, and that can sort of run the spectrum on how intimate you are with your patients. We need to make sure that we are being intimate and friendly enough without overstepping that boundary. Remember, you are the leader of this relationship. You are the one who brings it to the table. There's going to be this close balance. And that patient is going to rely on you to sort of set forth these standards. Listen to your patient. Make sure that you are understanding their story. We talked about the patient's story already to determine their level of comfort on how close they want you to be. Every patient is different, so you need to make sure that you are figuring that out per patient. As a society, we don't condone touching, especially among strangers. So if you think about when you walk into an elevator and there's someone already on the elevator, what do? Typically, you step to the complete opposite side of the elevator to allow that distance. There are a few instances where it is acceptable. If you've ever watched a sports game and someone scores a touchdown and they pan to the crowd and the crowd is cheering and you see people hugging each other, they didn't know the person next to them. It's just almost acceptable to kind of impulsively hug that person when something happens. Our profession requires a lot of touching. There's no ways around it. It's just what you're going to do, and it must be done. So you have to make sure that you're doing it respectfully. It can be a means of rapport with your patients or showing reassurance. There's a lot of times where I would put my hand on their shoulder or on their arm. That's sort of how I built up my relationships with my patients. But I also recognized who wasn't comfortable with that either. There is unconsented touching, which is also defined as battery is the legal term. That's why informed consent is so important, because you need to make sure that you are getting that each and every time. Okay, I'm going to stretch your shoulder today. Is that okay? Yes, you got your informed consent. Even if it's another day, some days are more comfortable than others. You need to make sure that you're getting that permission from your patient to actually make that physical contact. Some cultural, social, and personal factors can come into play with the patient's comfort zone. We've already sort of talked about that. Culturally or religion can play into tune, but just be in tune with what your patient is kind of responding with to you so you understand where to go next. So unconsented touching, you'll need to know the difference between sexual touching and sexual harassment. Sexual touching is unacceptable physical contact, can be charged with sexual abuse. It betrays the reasonable expectations set forth in a betrays reasonable expectations set forth in professional and patient relationship. I was trying to read something in my book while I was reading that. The book talks about on page 212 that the American Medical Association addresses the broader notion of sexual misconduct. Why should it be forbidden if a competent adult patient consents to or even seems to invite sexual contact? The strongest argument against this type of contact is that it betrays the reasonable expectations built into the essence of the health professional and patient relationship. Patients have a right to receive the best care possible without having to satisfy the professional's needs. And it does go into another paragraph. However, what about the idea that sexual activity between professional and patient may be taking place between two consenting adults? An objection to this argument is that sexual activity is never free from other types of claims on the other person. So both patient and health professional may begin to alter the conditions of the relationship in light of the power of its sexual dimensions rather than the conditions under which a patient sought professional care in the first place. In short, it is never considered fair that the patient would have to meet your need for sexual pleasure, sexual intimacy, sexual fulfillment, dominance in a relationship, or any other gain, no matter what the patient might believe will be gained. So really, think about what it's saying there is that some people say, well, what if the patient and therapist say that it's both okay? Then it should both be okay. Well, no, because that's not what the patient came there for in the first place. The patient came there for the treatment. That's what the patient should be, and the relationship shouldn't be changed. There is sexual harassment, unwelcome sexual advances, requests for sexual favors, and other verbal or physical contact. Any activity that creates sort of a hostile work environment. Most state licensing authorities have provisions prohibiting such behavior, such as ours. There was a study done for PT. 63% of respondents reported having experienced some form of sexual harassment perpetuated by patients. I can say that I would be part of that 63%. I've also been sexually harassed by a doctor once, which is both with a doctor and patient, is very awkward, and it's very uncomfortable, and it has to be approached appropriately to make sure that nothing is actually happening. And each work is a little bit different, so just making sure you understand where to go with your work. There's a thing called dual relationships. This is when a professional assumes a second role with a client, becoming a friend, employer, teacher, business associate, family member, or sex partner. This can begin before, during, or after the relationship. Usually involves a professional who rationalize the behavior and say, no, it's fine. It's a unique situation. For when I worked at Select, you were not allowed to be friends with your patients. You just weren't. Every clinic is a little bit different in how they think. There is this crossing of that boundary again when a patient comes in. They're coming in for this expectation of treatment and professional behavior and your expertise. And sometimes when it crosses over, it can be a little bit unethical. But again, there's more research that needs to be done in this area to see what is and isn't appropriate depending on the type of relationship that you're having. So just understand what your work expects from you. If it's something in your employee handbook that says you can't do that and they catch you doing it, then understand that you might have crossed that boundary and you could get fired. I believe that it can cause difficulty and really a challenge for you depending on what that relationship is presenting, because really you can get into a personal friendly relationship with someone and you are starting to spend more time with that person in the clinic. That can cause issues with your other patients. Just be aware and understand that that is a thing. The book talks about enmeshment, which is an emotional response and psychological attachments of the health professional or patient that can interfere with respect. This can go both ways. This is really impossible to maintain over a lifetime, and these challenges can include sympathy slipping into pity, over-identifying with the patient, and misjudging the scope of caring a patient. Enmeshment sort of, you are just fully, really enmeshed, like meshed together with your patient, and that can be that can get kind of challenging. So sympathy turning into pity. Pity, one person looks down on another. I never really liked that. I never wanted anyone to pity me for something that happened to me, and I feel like some of our patients sort of run with that. Most health professionals can name at least one illness or injury that affects them emotionally. For me, it's lung cancer. My Grammy had lung cancer. Both my mother and father-in-law died from lung cancer. So there is just something about it that when a patient comes in, it's very hard for me to approach. So I understand that, and I know that I could get too emotionally enmeshed in that patient in trying to fix them or heal them. So I need to make sure that I'm approaching those situations appropriately, or if need be, having another professional take over if I feel like I can't actually handle that, and I might take that home with me. That wouldn't be healthy for me. People tend to respond impulsively instead of with genuine care. And then my facial expressions, I can be too nervous or sudden departure. I might have to leave quickly because I'm thinking too much of my Grammy, who had also died from lung cancer. So some of these things you need to be aware of. It doesn't mean that you're unfit to do your job. It just means that you have to be aware of that and that you are not changing how you're treating. So over-identification with the patient. This is trouble seeing the patient as a unique individual. It might remind you of someone else. That's that countertransference we talked about earlier. It might have had a similar experience. So what I have found is if a patient comes in and talks about a broken foot, oh, well, I had a broken foot. This is what happened to me. And I start interrupting their story with my own story. And that's that over-identification. This is also another version of enmeshment. I'm sort of enmeshing myself with my patient because they had a broken foot and I had a broken foot, and this is how we're the same. Again, that's over-identification. It's okay to inform your patient of these things, just making sure that you're keeping that distance. Caring too much. Awkwardness that comes from relationship that started with appropriate boundaries, but circumstances arise that require a reestablishment of these boundaries. Typically, this is, again, spilling over into the enmeshment of you and your patient. Really, you are acting on good faith because you want the patient to be better, but it comes too much of a dependence between each other. And that's sort of when you see that one person is clinging to another. Again, either whether the therapist to the patient or the patient to the therapist starts clinging to the other one. Again, remind yourself of these patient to therapy boundaries and that you're maintaining them. Maintaining your boundaries for good. So if we're talking about sympathy turning into pity, we are not trained to solve every single problem that your patient comes in with. Your patient will come in with a total knee replacement, who tells you about their current divorce, their money problems, their this. You're not trained to psychologically help your patient to that extent. Just making sure that you're ready to refer those out if necessary. It's okay to listen to your patient. Just be aware of some of the advice that you're giving. When coworkers see a situation, sometimes this over-identification happens, and you may not even recognize that it happens. Allowing your coworkers to speak on behalf and listening to your coworkers if they see that you're getting too close, and vice versa. Just respecting that boundary of the patient and maintaining a healthy relationship. Rule of thumb, never visit a patient in a social setting until the patient feelings won't get hurt. And remind the patient of a real situation between them, that you are just a patient-therapist relationship, and that's really what it should be. Again, make sure that you are aware of your boundaries and that your boundaries that your work is setting for you, so you are not crossing them. The last thing you want to do is cross that boundary and get fired because of it. So if you guys have any questions on Chapter 11, please let me know. I am happy to answer them. Thanks, guys. We'll see you soon.